Welcome to the deep dive. Today we're plunging into something pretty serious, gastric varices, or GVs.
Right.
These aren't just, minor issues. They could be life-threatening ruptures, a major complication for patients with liver cirrhosis.
Absolutely, a leading cause of death in that group.
But there's hope, right? A set of techniques called Retrograde Transvenous Obliteration, RTO. That's BRTO, PARTO, CARTO.
Exactly. These are powerful endovascular interventions.
So our mission today is to really unpack how radiologists use anatomy, careful planning, and imaging to pull these off. This dive should give you a real shortcut to understanding this complex field. Let's jump in.
Okay, well, what's really key here, and maybe surprising, is how much success relies on truly understanding the specific anatomy of these GVs.
The plumbing, basically.
The plumbing, yes. And Saren's classification helps us here. It tells us not all GVs are the same risk. IGV-1s, isolated gastric varices type 1, those are the ones we worry most about bleeding.
And highest risk.
The highest risk, yeah. Along with GOV2s, they're the main targets for RTO. Knowing this dictates, who needs urgent help.
So when you're mapping this out, are you looking for the ins and outs, like inflow and outflow veins?
Precisely. The inflow, or afferent veins, often the left gastric posterior gastric veins. And Kiosu's classification comes in handy here.
How so?
Well, it helps map the unexpected. Think of it like this. Sometimes, in type 2 or 3 cases, an inflow vein can suddenly act like an outflow drain during the procedure.
That's okay. Paradoxical.
Right. And if we don't spot that, the sclerosant, the stuff we use to clot the varix, could leak out.
Leak where?
Into the main portal system. That's the big network feeding the liver. It can be, catastrophic. So spotting that risk changes our whole approach.
Got it. And the outflow pathways, the efferent veins.
Yeah, the main one is the gastrorenal shunt, the GRS. You see it in maybe 85% of these cases. It's pretty much essential for doing RTO in the first place.
And there's grading for that, too. Hirotas.
Hirota's grading, yeah. It tells us about the flow, the hemodynamics. High grades mean lots of collateral flow, making the procedure technically trickier, like navigating rough waters.
Wow. It really sounds like more than just fixing a leak. It's major internal rerouting. That must need incredibly careful planning beforehand. What's the blueprint look like?
That's exactly right. It's all about the planning. High-quality imaging is non-negotiable. We're talking computed tomography angiography, CTA, or magnetic resonance angiography, MRA.
Not just standard scans, then.
No. This is like surgical level planning. We get a detailed 3D map. We map out the shunt shape, check if the portal vein is open, look for any reasons not to do the procedure. Doppler ultrasound, useful sometimes, but not for this level of detail.
And are there absolute no-goes? Things that stop you completely?
Yes. A big one is complete thrombosis, a clot, in the main portal vein, the MPV.
Why is that so critical?
Because if the MPV is blocked, the gastrorenal shunt becomes the main drain for the whole gut system. If we then block that shunt with RTO...
Oh, you cut off the only exit.
Exactly. You risk catastrophic mesenteric ischemia. Just devastating. We also do thorough clinical checks, liver function, kidneys, fluid levels, and always an upper endoscopy first.
To check for other risky varices.
Right, like in the esophagus. Gotta rule those out.
It's amazing how much prep goes in. So these RTO techniques themselves,
Yeah.
BRTO, PARTO, CARTO, they've evolved. What changed?
They have. We started with BRTO, balloon-occluded RTO, involved inflating a balloon in the shunt, injecting the sclerosant, and keeping the catheter in for a while, sometimes hours.
Hours. That sounds lengthy.
It was. The big leap forward was PARTO plug-assisted and CARTO coil-assisted. They use mechanical blockers like vascular plugs, often sized up a bit, maybe 20-30% bigger than the vessel for a tight fit or coils, instead of just the balloon.
And the advantages?
Speed and safety, mainly. Much shorter procedure times, minutes instead of hours, and fewer issues related to having a balloon inflated for so long. It gives us more control over delivering the sclerosant.
Speaking of the sclerosant, has that changed too?
Oh, absolutely. A huge shift. We used to use ethanolamine oleate, but it had some really serious side effects, breaking down blood cells, kidney failure, things like that.
Not good.
Definitely not. So now we mostly use safer options like sodium tetradecyl sulfate, STS, or piracetamol. They work just as well, but are much, much safer for the patient.
So better techniques, safer materials. Are there still potential complications?
Yes, even with success rates often hitting 90–99%, we watch closely. Sometimes blocking the shunt can worsen portal hypertension elsewhere, leading to more fluid buildup like ascites or even new esophageal varices. And sometimes the shunt can reopen later, what we call recanalization.
So to wrap this up, successful RTO for gastric varices really boils down to this incredible mix of knowing the anatomy inside out, using precise imaging, and constantly refining the tools and techniques.
That's it. And maybe a final thought for you to consider. All this incredibly detailed work that happens before the procedure, the stuff the patient might never even see, that's often the real key to success. It's like a silent guardian, ensuring safety and the best possible outcome in these really high-stakes situations. It highlights how preparation truly saves lives in modern medicine.